Right. So the aim of this morning's webinar, just for a background before I disappear, the intention was, obviously we've invited Amit back. Thank you for your time, Amit. Appreciate that. Is to give a sort of an update on the current situation for coronavirus patients, for acute patients during the coronavirus pandemic. And a lot of the slides, if you joined our last one, these will be sort of familiar to you, but there's also a couple of obviously updates around recent government announcements that we will be able to share with you. And I believe it also has some data to share with you around how acute patients have actually been directly affected by the coronavirus pandemic. So Zach, have you now got control of the screen?
We'll give it a go. Let's see. No, it's not letting me click through.
I think it's a slight delay. But...
let's try. Let's see whether this. There we go. Right. Okay. So for context, I think this is the purpose of.
Apologies. That's me.
The general government guidance for blood cancers is that people with cancers of the blood, such as leukemia, and obviously that includes acute leukemia, are considered clinically extremely vulnerable. Now, this is deliberately a cautious approach that the government are taking, because obviously the coronavirus is something new, not something that we've previously encountered, and therefore the evidence base is very limited, but they suspect that people are clinically vulnerable, and therefore we're learning more and more about this every day. Let's see if it advances to the next slide. There we go. So just to recap what that means, is that anybody with acute leukemia, those in remission, 1 year out of chemotherapy, a couple of years out of transplant, are all considered clinically vulnerable and should be shielding. And if you have questions about it, you should be speaking to your haematology team and finding out more from them. And if you have symptoms that you suspect to be the coronavirus, you should also be speaking to your haematology team as well as presenting in the normal routes. Let's see, advance to the next slide. So some of the questions that obviously people have, and I'm sure we'll get to these in the Q&A, is how long this is likely to continue. At the moment, obviously shielding has been announced for 12 weeks. That takes us up to June. We're expecting further announcements this week, perhaps, on what will happen beyond that. But the current status, as far as we know, is we genuinely just don't know. I know that's not particularly helpful for people. But that is the situation. Nobody knows, and really we would reassure you to try not to speculate or make any decisions too early. At the moment, the situation is obviously shield up to the end of June. I know that makes it difficult to plan beyond that, but it does mean that we have a while yet. So do try not to speculate as to what will happen beyond that, or worry about the uncertainty or the unknown. But if you do need any support or have any questions around that, reach out to charities such as Leukemia Care for questions. So just again for recap as to what shielding means and the difference between shielding and the lockdown that the rest of the population is currently in, and obviously which is changing following the announcement, it's certainly in England, from the Prime Minister. So shielding, for those who are considered clinically extremely vulnerable, and that includes all acute leukemia patients, is that you don't leave the home, even for exercise, even for shopping. So the reasons that apply to the general population for leaving the home do not apply to those who are meant to be shielding. The only exception to this is to leave the house for medical appointments, and that is obviously at the request of your clinical team. And if you have any concerns with that, obviously speak to them and balance that. One of the other pieces of shielding guidance is that if you live with other people who are still leaving the house, if you use shared spaces, try to do this at different times, and wherever possible, clean between uses. Use separate dishes, cloths and towels if you can, and wherever possible, stay apart 2 meters from them at all times and sleep separately if you can. Now, obviously not for all people, that's not going to be possible. I'm sure that's something we'll discuss when we get to the questions. So one of the ways in which people know they are vulnerable is that they should have received a letter from the NHS. They have been sending out letters to confirm vulnerability. The initial assessment that this would be 1.5 million people. It's now likely to be nearer to 2.5 million people. And one of the challenges with this is the NHS doesn't maintain a central record. So this is all being done at an individual hospital and GP level. Based on the categorisation of the government. So there have been teething issues. Many people have still not received their letters. Despite that, if you consider yourself to be vulnerable, you should be shielding in the meantime. Obviously, this can create questions and problems if you can't access the support that comes with receiving a letter. But you can register for support in England via a central system. Or anywhere else, as well as in England, contacting your local council to find out what support is available for you. If you haven't had a letter and you have a problem, contact your GP to see if they can sort a letter, and also contact your haematologist and let Leukemia Care know, because we're trying to understand how widespread this issue is and also trying to support people in accessing support. So in terms of treatment changes, obviously this is something that people will be worried about if they're currently undergoing treatment. And the general guidance is that doctors are making a risk-benefit analysis. Oh, it's jumping forward. Are making a risk-benefit analysis for all of these. Obviously, there is a risk of contracting coronavirus if you're going into hospital for treatment. Also, there is, of course, a risk with your acute leukemia. So these are risks that have to be balanced. And the guidance from NHS England, particularly now, is that the urgent cancer treatment remains a priority. And I'm sure Amit will be able to talk more about this specifically from an acute leukemia perspective.
I'm going to just spend the next couple of minutes talking about blood cancers, acute leukemia, and of course, a lot of patients with acute leukemia will then go on to have stem cell transplantation or CAR T cell therapy. So I'm going to touch on all of these aspects if I can. I think the first thing to say, as Zach's pointed out, though, is that shielding is very, very important. And for patients who haven't been contacted by the government or by their local hospital hematology department, then it's worth making sure you're registered, and the government website will allow you to do that. There are lots and lots of guidelines that have been produced, and I think it's fair to say, echoing what Zach said, really, that the evidence base for these is very sparse. So these are mainly based on very limited data and consensus opinion. And NICE has produced some, you can see, for transplantation, for anti-cancer therapy, and for treatment of younger patients. And all of the groups outlined here, supported by the government, have contributed to this work. As a patient, I think the important things are to consider whether you've got respiratory symptoms. And of course, fever, cough and fatigue with shortness of breath are the commonest, but there may be some other less specific features like general myalgia or chills, or even dizziness and headaches have been reported, as well as diarrhea in younger patients. So any of this symptomatology in the current climate may be a manifestation of COVID-19. And the reason the symptomatology is predominantly respiratory is shown by these CT scans. These are from a patient in France who had a blood cancer and then got COVID-19. You can see here that the lungs should look fairly black, filled with air, with very little else going on. But you can see here there are these exudates starting to appear. And then you can see for this patient, the entire lung has been on both sides infiltrated quite heavily. And you can see on in this picture that there is a more subtle infiltration, but it's still there. And unfortunately, in this patient's lungs, you can see that the lung has been completely destroyed by the infiltration. So you can see that a spectrum of involvement and a spectrum of severity is experienced by different patients. If you are worried that you have any symptoms that could be consistent with COVID-19, or you're worried you've got non-specific unexplained symptoms, I think the first thing to do is make sure you contact your hematology team and the leukemia team if you have access to them, or your transplant or CAR T-cell center if you've had those treatments most recently, rather than the government guidance, which is to contact 111. I think the first port of call should be your treatment center. And then they may direct you to 111 if it's felt that you don't really have symptomatology that would be of concern for admission. The important thing about fever, whether it's on its own or whether you have other symptoms with it, respiratory or otherwise, is that this may be a manifestation of sepsis. And of course, patients with acute leukemia typically have a high risk of neutropenic sepsis due to bacteria and fungi or viruses or any combination of those. So it's very important to engage in the normal way you would with your treating center to make sure that you receive very rapid and emergency treatment. And of course, you will be screened for COVID-19, and if that is diagnosed in addition, then additional measures will be taken, including isolation and if there are any clinical trials available for that infection, then they will be offered. But I think the important thing is not to miss infection from other causes, which is probably just as common, if not more common. In terms of what hospitals are doing, I think most patients will have already experienced that they've been asked to attend alone. Very few trusts are allowing patients to bring carers with them. They're being asked to spend the minimum amount of time in the waiting area. So, for example, not attending too early, or waiting in the car or waiting outside for their appointment, rather than waiting in the waiting area where in the past lots of patients would be waiting and there'd be a risk of transmission. And certainly you wouldn't be able to physically distance 2 meters very, very easily in that setting. And of course, a lot of patients, because they're shielding, are being risk stratified by their hematologists and actually being offered telephone or video consultations in lieu of face-to-face consultations if that's appropriate. And some patients who do need blood tests or transfusion support are being scheduled to have them at a different time to when clinics would normally occur. And again, that's to reduce the footfall and to reduce exposure to other people, to permit as much as possible some physical distancing. And in terms of treatment for acute leukemia, that's also being modified. So patients are being screened before initiating treatment of any sort, whether it's the beginning at induction therapy or subsequent lines of therapy. Patients are being nursed with single rooms if they're available, and certainly barrier nursed. I can tell you in our hospital, we have cohorted patients to COVID-free zones and COVID zones if patients are diagnosed with the infection. Patients who are partway through infection are being monitored more closely, and subsequent cycles of treatment are being deferred in patients who have very low level or undetectable disease by these methods. Patients receiving maintenance therapy for acute lymphoblastic leukemia are being extended, and so the subsequent cycles of chemotherapy are potentially being delayed if that's safe. Patients with acute myeloid leukemia are being offered intensive induction therapy with venetoclax-based regimens, initially to try and reduce the time required in hospital, and potentially reduce the time that the blood count is low or very low. Some patients with relapse disease, if they have FLT3 mutation present, are now being offered gilteritinib instead of less intensive, and allows patients to spend more time at home rather than in hospital. And patients who have already achieved remission are perhaps being offered omission of the last cycle of consolidation, for example, if they've got no detectable disease by a sensitive method. So all of these options, I think, will be discussed with patients when they see their hematology team. But I think these are some of the options that have been really made available via the NHS because of the pandemic, really with the aim of trying to facilitate shielding in the best way possible to reduce both hospital attendances in terms of time in hospital and the frequency of attendances. For patients who are being prepared for CAR T-cell therapy or for allogeneic stem cell transplantation, patients are again asked to be shielded, and they will receive COVID-19 tests within 72 hours of initiation of treatment. And of course, if patients have been exposed to others that have the infection, whether they're known to or suspected to, then they will have to be tested. And if they are tested positive, the transplant, if possible, will be delayed by up to 3 months. If it's not possible, then repeated negative PCR tests will be required before rescheduling. And this is really because there is a significant pre-symptomatic phase to both patients and contacts they've been close to. For patients who have had their transplant, Zach's already mentioned that really, if you've had an autologous stem cell transplant, you should be, within the last year, or even CAR T-cell therapy, you should be shielding. Or if you've had an allogeneic stem cell transplant in the last 2 years, you should be shielding. And even if you've had your transplant more than 2 years ago, if you're still on some form of immune suppressive therapy, or you've got chronic graft-versus-host disease, or your team think you're vulnerable, then you should still be shielding. And centers are trying to reduce transmission by reducing visitors to the hospital, to inpatients, deferring clinic appointments if that's possible, and deferring treatment if that's possible. And for patients who have a donor as part of their transplant, the donor is now being harvested in advance, and their frozen stem cells are being transported to hospitals prior to commencing treatment, whereas in the past, a just-in-time delivery mode was utilized. I just want to move now on to some data, because I think we've now got a little bit of an insight into how patients with blood cancers and patients with acute leukemia are faring with this infection. This is an American registry, but it's a global registry. And you can see that the number of patients registered with acute leukemia is the highest out of all the different types of blood cancers, despite the fact that acute leukemia is probably one of the least frequently diagnosed types of blood cancers compared to the others. Mainly men are affected, which is the same as the general population, and mainly older patients are affected, which is similar to the data for the general population. Most patients will have moderately severe disease, with equal numbers getting very mild disease and severe disease. And I have to say, we've seen similar patterns as well. So we've seen patients who have got COVID-19 with very low blood counts, or patients with leukemia that are post-transplant, who are perfectly well in the community and don't require any intervention. And similarly, we've seen other patients that become very unwell very quickly and do need intervention. In terms of COVID-19 related outcomes, you can see most patients are recovering, but unfortunately, we are still losing a proportion of patients to this infection. Patients with acute leukemia, as we said, are most frequent, and we can see that as a proportion of those patients, most people would expect to recover. In terms of their disease prognosis, you can see patients who have a prognosis of more than a year will have the highest likelihood of recovering. And unfortunately, patients who have a prognosis of less than 3 months or 3 to 6 months have a much higher risk of a poor outcome with this infection. Patients who have an initial diagnosis, so in other words, uncontrolled disease, relapse refractory disease status, or patients who have stable disease but nonetheless have the presence of the disease, have the highest risk of a poor outcome with this infection, whereas patients with a remission tend to have a much better outcome. Most patients with COVID-19 who are having treatment at some point or had treatment recently are at the greatest risk of not surviving from the infection. And similarly, patients who have a low blood count are vulnerable as well. Patients with initial diagnosis and patients with stable but persistent disease are at risk, as mentioned earlier. And if I talk about acute leukemia on its own, you can see there's not a lot of patients, but there's a spread with some younger patients with acute lymphoblastic leukemia being affected. As most patients will have mild to moderate disease, most patients would expect to recover, but unfortunately we would still expect some patients to succumb to the infection. In terms of treatments that are being offered, most of these are offered within the context of a clinical trial: azithromycin, hydroxychloroquine, remdesivir. But we don't know if any of these are currently successful or working for our patient population. And for leukemia in particular, we can see that patients who have a prognosis of less than 6 months are unlikely to survive if they come into contact with this virus based on the small numbers that are available. We've already talked about the low blood count being a risk factor. And for acute leukemia, you can see that time from recent treatment is also a risk factor for succumbing to this infection, whereas patients who have completed treatment some time ago are at a lower risk from problems. And similarly, for acute leukemia, as is the case for other blood cancers, relapsed disease, stable but present disease, or newly diagnosed patients with disease are at most risk, whereas patients in remission or patients receiving consolidation in the absence of disease are at lower risk. Similarly, patients who are being treated for induction are at the highest risk compared to patients who are receiving consolidation. And then if we look at UK data, and this is a data set of 17,000 patients identified from GP records, you can see that patients with any form of non-hematological cancer compared to the general population, which is depicted here, are at increased risk of not surviving from the infection related to how proximate their cancer was diagnosed in the last year compared to the last 5 years compared to more than 5 years ago. In patients with blood cancers, however, are at the highest risk and much higher risk than other types of cancers. And even patients who have had their cancer diagnosed more than 5 years ago appear to be at nearly twofold higher risk compared to any other type of cancer that's in any stage of their treatment or diagnosis. So I think it is right, therefore, that the government advice is that patients with blood cancers, particularly patients with acute leukemia, are shielding. We know that older patients, as you go up every decade, are at increased risk of not surviving from the infection. We know that male patients roughly are at twofold higher risk compared to female patients. And we know that other risk factors are also important. So obesity increases risk of a poor outcome. We know that deprivation increases the risk of poor outcome. And we know that diabetes increases risk of poor outcome. And in fact, most medical comorbidities, whether that's chronic lung disease, chronic cardiac disease, chronic liver disease, dementia or other neurological problems, renal impairment, a dysfunctional spleen, autoimmune disease, other immune suppression, or in fact an organ transplant in the rare number of patients who have got leukemia and have had an organ transplant, those are all additional risk factors as well. So I'm going to stop here, and we can take questions. I think the important messages from my point of view are really echoed from what Zach said, and I think the key message here is that we don't really have any specific treatments for COVID-19, and therefore shielding is the best preventative maneuver available to us at present to try and prevent both infection and try and prevent poor outcome from both the acute leukemia and treatment related immune suppression.
Thank you for that, Amit. I think that was a really, really good overview of what we've learned since we last came together to do a webinar. I just wanted to start with the messages on the treatment changes as a sort of a first sort of question, more of a comment from me, I guess. I think what I've gathered from what you've said about people who are continuing to receive treatment at the moment is that there are alternative chemotherapies being put in place to help them avoid hospital where possible, and obviously COVID testing is really important at this time, especially for those pre-transplant. Is it fair to say that things have gone surprisingly well in terms of how the NHS has coped with still treating blood cancer patients at this time? Would you say that's a fair assessment? You're on mute, Amit.
Sorry, I think I would agree with that. I think the contingency plans have been put in place to try and defer treatments where that's safe to do so, and to prioritize treatments for patients that really need treatment at that time. And most centres have developed policies for this. And going forward, I think Zach already mentioned the government is prioritising cancer treatment. And so our centre, like many others, are classified as COVID cold sites. So we are trying to make sure that we're able to go on delivering anti-cancer therapy to patients. And in patients who then develop COVID-19, which will occur, we have plans to cohort into COVID areas of the hospital to avoid cross-transmission. And most hospitals have policies similar to that in place.
And we've had a few questions from patients about PPE use when treating blood cancer patients, and you talk about barrier nursing for those who are in hospital as an inpatient, but if you've got anything to share that would reassure people who are concerned about coming in for appointments and things like that at the moment, in terms of what is being done to protect them.
So I can tell you what's going on at our trust, which I think is similar to most of the advice provided by NHS England. So where patients need to come in for clinic visits and other treatments, staff are wearing PPE. So they are wearing masks, gowns, visors, both to prevent transmission from staff and also to prevent transmission from patients to staff and therefore ongoing transmission thereafter. In terms of patients, what patients can do, I think the hand washing, use of hand sanitizers is important. And I think the government has changed their advice in the last couple of days to say that cloth face masks would be beneficial at preventing transmission from patients. to other individuals if they are either infected or in the pre-symptomatic phase of infection. And there is modest evidence that this is helpful. So in other words, if everybody is wearing a mask and is adhering to good hygiene and physical distancing as much as possible, then that will reduce the risk of transmission. It won't eliminate it, but I think it will significantly reduce the risk of transmission.
Absolutely. Just moving on to some of the data you presented on the patients that have already had or had experience of COVID. And it seems broadly that those who still have disease present at the time are those that are most at risk. I hope I've summed that up correctly. But would you say then that broadly the shielding guidance is correct in terms of who specifically is identified as clinically extremely vulnerable? Does this sort of validate sort of guesses we were having to make a few months ago?
Yeah, I would agree with that, because I think when the shielding advice was devised, we didn't have data to help support the decision making. But I think the data, as limited as it is, the data that's available does indicate that it's broadly correct. Patients who are immune suppressed, patients who have evidence of disease, patients who are proximate to significant therapies like stem cell transplantation or CAR T-cell therapy, all of these groups are at the highest risk. And I think the advice would be that shielding would be the best way to go here. And if there are additional other medical factors that I touched on, as well as the blood cancer, the acute leukemia, then that will be additive to that risk.
And there's an interesting question in the chat about whether the information we've now got will allow for further sort of clarification or stratification of patients who may be at less risk. Do you think that that would be a sensible approach, or is it better? I mean, obviously you're not in charge of the decisions. The government will probably make a decision based on this, but from a clinical perspective, do you think it would be sensible to further stratify patients, or would that be further confusing for everyone?
I think it'd be hard, as you say, for the government to do this, but certainly patients that are concerned about it should discuss it with their clinical team, because of course I've had these discussions in clinic with my patients, and there are some patients that would technically fit into the shielding category, but actually they are at a lower risk compared to other similar patients. And so if they chose not to shield but continue to do what everybody else is doing in terms of physical distancing and hygiene precautions, then that would be reasonable for those patients. So patients, for example, who have completed treatment some time ago are no longer being monitored and have no evidence of any residual disease, those patients would potentially fit into the general population risk. And then things like other medical problems, age, gender would then play into that.
Absolutely. So the message is for anybody who's not sure whether they should be shielded at the moment, definitely contact your clinical team for further clarification on that. So the question here, I guess this is related to the data presented. Apologies if I misinterpreted this, but someone's asked if low immunoglobulins specifically have been involved in risk stratification of people, or whether there's been any information as to whether those with low immunoglobulins are at higher risk or not. I don't know if that was covered in your presentation. Apologies if I missed that.
No, I didn't really talk about that because it's not specifically being looked at. Because of course, patients who will have low immunoglobulins because of their disease, patients will have low immunoglobulins because of treatment. And it's not clear whether that is a risk factor, an additional risk factor on top of the fact that the patient has cancer and is receiving treatment at this time. So on its own, I don't think low immunoglobulins is really able to risk stratify patients based on what we know currently. However, the cancer diagnosis, the remission status, and recent treatment and the intensity of that treatment, I think, would guide better the risk.
Thank you for that. There's a very interesting question actually that I've not seen before. It's just come in. Apologies for looking like I'm reading them as they come. But yeah, it's a very interesting one about whether COVID-19 treatments could be used prophylactically for those who are most at risk, similar to what we do with antibiotics. I mean, it's probably a bit early to be saying these things for sure, but clinically, what do you think that could be a strategy that could be looked at in the future?
Yeah, I think there are studies looking at this, but I think that we know at the present that there are no prophylactic or therapeutic treatments that are proven to be effective. There are lots of anecdotal data that have been published and are flying around the internet about various treatments. But they're small studies in cohorts or some small randomized studies, and none of them have definitively shown, that we should adopt a particular approach. But I think it is being looked at, and if one or more drugs is safe enough to take prophylactically, such as hydroxychloroquine, which is one of those that's been looked at, then certainly that will be adopted. But nobody has shown whether this is beneficial, and nobody knows how long you should take it if it is beneficial. I think a lot of work is going on, and I think in the next couple of weeks to months we'll get some of the large studies presenting their data, so we'll have more information.
It's certainly a very interesting time for science, if nothing else, I think. Yeah, very interesting.
In the UK, Charlotte, patients in the community can be enrolled into the principal trial, which offers hydroxychloroquine versus placebo for patients who have, by definition, not some symptoms, but don't have severe manifestations of COVID-19.
Absolutely, it's
patients with
important.
More severe disease will be enrolled into clinical trials in the hospital setting.
Thank you for sharing that. Zach, do you mind if I fire an advocacy-related question your way? We've got a question here from someone who initially was told by their hospital and the GP that they didn't need to shield, but have recently received their shielding letter, and they were wondering why that had occurred and why there was confusion initially at the start. Could you comment on that for me?
Yeah. So I mean, it's hard to obviously comment on their specific case as to what has prompted the shielding letter to come through. But I would say that shielding letters are being issued by both hospital and GP settings. So I would certainly be following the shielding letter that you have received until you've had a chance to speak to your healthcare team and find out what the particular risk is to you. We know that the NHS have had a variety of issues getting the shielding letters out as quickly as they anticipated. So I don't know when you received the shielding letter and when specifically you spoke to your GP, but it's likely that the time delay is as a result of that. We know approximately 20% of those we would expect to have received a letter still haven't done so at the latest ask of our survey. So certainly do follow the letter you've received and go and speak to your haematology team, as Amit's been saying, to find out specifically what the risk is for your situation.
Yeah, we've had quite a few people asking sort of specifically for their situation if they should or shouldn't be shielding, and that's not something we're able to answer in this webinar. Unfortunately, we'd really encourage all of you listening, if you're not sure, to speak to your clinical team.
Charlotte, can I just
of course,
say something about that? I would absolutely agree with both of you about that, because I've had a number of patients ask me similar questions in clinic. They've received a letter from their GP, the government, and our NHS trust, and they're all slightly different. I think the the most important thing is to ask your clinical team, because they will know you better than anybody else, and they will be able to advise whether you should be shielding or whether you shouldn't. And if you're not shielding, then of course you should still be physically distancing as everybody else is.
Thank you for clarifying that. And one other question your way, Zach. If people are concerned due to recent government announcements about other people in the household being encouraged to go back to work or children being encouraged to go back to school at some point soon, is there any precautions they need to be taking to alleviate that? Is that something they should be concerned about? And can they get help if they're concerned about that as well?
So again, one of the things I would encourage you to do is to minimise the risk where you can. So obviously, if people are going out, it varies as to what situation they're going out to. Many of you will live with frontline kind of key workers who are going to hospitals. So looking as to where you can distance from them, I appreciate that's really not possible in a lot of people's living situations. And the other thing is to, again, speak to your healthcare team, find out specifically what risk you are at. And if you are really, really high risk, then obviously you need to be more stringent as to what precautions you are taking. And again, the options that are available for people will vary. I mean, we had some yesterday on the webinar we did where people said they were living in a separate home from partners who had distance because they were at particularly high risk. Everyone needs to follow the decisions they think are appropriate for them and for their individual situation, but do so on the basis of guidance from your clinical team.
Absolutely, yeah. Amit, one last question to you before I talk about extra support. There's a question we've had about what people should do if they're concerned about relapse at this time or their leukemia coming back in sort of any form at all. What advice would you give to those people who are concerned at the moment about that?
So, if somebody's already in remission, their team should be monitoring them. For acute leukemia, that really is a bone marrow sample with blood tests. Now, if somebody has achieved a complete remission and there's no detectable disease or measurable residual disease at MRD, then the risk of relapse would be lower, and their clinical team will advise them as to when further monitoring should occur. And that could be slightly delayed to avoid hospital attendances. Patients who have some form of residual disease detectable may be at higher risk, and they may require more frequent monitoring, but that might simply be blood test monitoring. They may not necessarily need a bone marrow assessment for detecting the relapse. So it will depend, for ALL and different genetic subtypes of ALL, and for AML similarly, there will be differences. But the best thing to do is to make sure that your clinical team are involved, which I'm sure for most people they will be.
Yeah. The recurring message, I think, is if you have any concerns about any of the topics we've discussed, is to definitely speak to your clinical team. Thank you both for answering those questions. I'm just going to share my screen again so we can share further information that's available from us before we finish up. Yeah, so obviously Leukemia Care have been working as hard as possible to get information out to all patients during this difficult time, not just these webinars, but also through newsletters, magazines, our podcasts and our social media. So please, if you don't already like or follow us on any social media you use, please do so to keep yourself up to date. And then all of our support services broadly are still available, our helpline and our WhatsApp service, and we've actually got a fairly new service for welfare advice if you are struggling financially at this time. So please do get in touch if you need any sort of support, and you can see our generic helpline number and our email address at the bottom, and feel free to get in touch and we'll pass you on to the relevant team. And of course, there are also other charities that may be able to support you for acute leukemia. The most relevant would be our colleagues at Blood Cancer UK. Thank you for your time, both Amit and somewhat unexpectedly Zach, and we'll see you all next time.
Thank you very much. Bye-bye.
Thanks. Bye.